Welcome to the next patient information. This is on keyhole surgery of the shoulder. What is keyhole surgery? Keyhole is where I undertake numerous different types of procedure using small 7 to 8 millimeter cuts on the shoulder and using thin pencil-sized instruments to perform a variety of procedures to the shoulder. What sort of procedures can be done? So, in the shoulder, I undertake a variety of procedures, including what we call as a shoulder decompression, wherein patients with shoulder pain who have spurring at the front of the shoulder, an inflamed bursa, this is removed, and the spur is removed using special burr and a radiofrequency probe, to using the keyhole for doing rotator cuff repairs. I also use the keyhole surgery for stabilizing a shoulder in patients who have recurrent dislocation, or what we call as in medical language as instability of the shoulder. It's also used to do keyhole release of the shoulder joint in frozen shoulder when patients have pain and stiffness. I've also used it for biceps labral lesion, which is described as a slap lesion, wherein the cartilage can be repaired, or biceps tendinitis, where I undertake biceps tenodesis, which means resighting of the attachment of the biceps from within the socket onto the top of the ball and socket. So in slap repair, this is the area where there is the tear, and this is the attachment of the bicep cartilage, which attaches to the top of the socket, peels off and tears from there, and on top of this attaches the biceps, the long head, and that can cause pain, especially on movement. So in certain cases this can be repaired by putting some stitches across here, or if not, then what I do is remove the biceps from here and then resight it to a different position somewhere along here, and this is all done through keyhole surgery. Patients who have recurrent dislocation, what happens is when they dislocate their shoulder the first time, what they tend to do is damage that cartilage like so at the top. So this peels off, and using special sutures, we can put some sutures here and then repair it back to the socket. Usually anywhere between 2 and 4 sutures are required, and this can be undertaken using keyhole surgery. In arthritis, what I do is use special instruments to perform what we call as chondroplasty, wherein multiple small punctures are made into the bone, and then followed by using a PRP, either from the blood or stem cells from the bone marrow can be done. A caution about the PRP and the stem cell is that it is still not completely approved, and it needs to be done under strict governance guidance, and I do offer these treatment to patients. So this is a model just showing the rotator cuff tear, and using keyhole surgery one can clear out the torn edges, repair this, and then using special stitches repair this tendon back to that point. The benefit of keyhole surgery is that we use small incisions around the skin and do not detach any muscles, which allows early recovery and rehabilitation. Certainly in the shorter term, the outcomes are much better compared to open procedures. The other advantage is that the hospital stay is less and patients can go home the same day. I occasionally do this in patients who are fully awake if they are not anesthetically fit. This also allows me to start rehabilitation fairly early, and I have started doing accelerated rehab in certain patients. How do I prepare for the surgery? You would have been given all the relevant information at your pre-assessment, either on face-to-face or via the telephone. You would be admitted either in the morning or a couple of hours before your procedure. All my keyhole surgery to the shoulder is done as a day case. I always advise to bring an overnight bag just in case you have to stay in for any other issues. On the day of this, you'll be advised to avoid to drink anything for 2 hours before the surgery and nothing to eat 6 hours prior to the surgery. Depending on which hospital you have the procedure, you will either be taken to your own room or to a pre-op care unit where you will be checked in by the nurses. Here you will also see the anaesthetist who will talk to you about putting you to the sleep and undertaking a block. I will also visit you before the operation, give you time to ask any questions, and also mark your arm to make sure that we do the right side. At the time of surgery, you'll be escorted by a theatre support worker to the theatre and will return back to your room. What happens after the surgery? I generally use a dissolvable stitch which I put under the skin. On top of this you will have butterfly stitches and a sticky plaster dressing. Finally, I put a big pad which allows to absorb any fluid that seeps through, as I use a lot of fluid when doing this keyhole operation. All patients also get a sling at the end of the procedure to rest the arm. This is for 2 reasons. One is to support from pain relief, and also because of the block the arm will be numb. The therapist will see you on the ward and will advise you for the exercises to be done immediately afterwards. We'll also provide you with an information leaflet. They will arrange for any outpatient therapy that is going to be required, either at the hospital or at a place closer to your hospital. The nurses will check you and make sure that you are recovering well, and once you are safe you will be allowed to go home, and this would include eating, drinking, going to the toilet and being up and around. All patients have what we call as a TED stockings, a compression stockings on the leg, which is required to reduce the risk of clots in the veins and the lungs. I generally advise to remove these once you are back to your normal mobility, which is within a few days after the operation. What happens in the immediate post-op phase is that your arm is covered with a big pad and a dressing, and you are in a sling. The pad will need to be changed anywhere from 24 to 48 to 72 hours, and this can be done either at the hospital or by yourself or a health visitor coming to your place. Following this, the keyhole will need to be stay covered with the sterile adhesive plaster dressings. After 48 to 72 hours you can get into the shower with the dressings on, and I advise the plaster to be removed completely after 10 days, and you can leave the portals or the keyholes free to air as long as they are dry. Sometimes the underlying subcuticular stitch can be felt just under the skin when you run your finger over the skin, but this generally tends to dissolve over the 3 to 4 weeks time. The sling is provided for comfort and also to provide support for any repair reconstruction that has been undertaken. I allow all my patients to start pendular exercises immediately afterwards once the block has worn off within 24 to 48 hours time, and then depending on the procedure you will be advised what activity and shoulder exercises can be done. If a repair or reconstruction has been undertaken, then you will be expected to use the sling for anywhere between 3 to 6 weeks time. The time to drive will depend on the type of procedure you have had done, and also partly on whether you have an automatic or a manual car. If there is no repair reconstruction, i.e. if patients have had a decompression or a capsular release or ACJ procedure, then I advise them to start to drive as they feel comfortable, which is usually anywhere between a week to 3 weeks. This will slightly depend on if you've had your left arm done, and if you've got a manual car, then this may take a bit longer. If you have a repair or reconstruction, then driving will be delayed by about 3 to 6 weeks, depending on the period of immobilization. In any case, I always advise patients to let their insurance company know so that they are aware of the procedure being done and you're not blamed for anybody else's fault. So far, I've never had any patients who has been stopped by their insurance company from driving. Return to work again depends on the type of procedure you have had done and also the type of work you do and what support your employers will provide you. Generally, if there is no repair or reconstruction type of procedure undertaken, and if it's light work, office-based work, then you could return to work at about 2 to 3 weeks time. This could apply also to patients who have had repair reconstruction but can go and sit in the office with the arm in the sling as long as they can get to and from the office. This is generally advised on an individual basis, and I tailor the return to work depending on the patient needs. Please discuss this at the time of your consultation. The risks of keyhole surgery are small, but certainly there, apart from the general complications of the anesthetic and the block. The keyhole itself can become inflamed, can have bleeding, infection. The risk of damage to the nerves around the shoulder is also present, but these are pretty rare and we take all the precaution to avoid this. Infection happens less than 1 in 500 to 1 in 1,000 cases, usually settles with oral antibiotics. Very rarely, if it's bad, then may need washout. Main risks associated are stiffness, persistent pain, and failure of the repair or reconstruction that has been undertaken. But this will depend on the type of procedure and the patient themselves. A small proportion, about 3 to 4 out of 100, will have persistent ongoing shoulder pain without any specific reason which we cannot find. And if that happens, then this will be investigated based on what the findings and the needs are. Finally, if you have any further questions, please do not hesitate to contact me. The information given here in my video applies to my practice and is fairly generic for any patient who has keyhole surgery to their shoulder. For specific information about your procedure, please discuss with your consultant.